Good afternoon, everyone. This week's, my name is Dr. Dominic Akateba. I'm with Ghana Medical Help. Today we are being led by Dr. James Sunkari. He's leading us with a presentation on pelvic inflammatory disease. Most of us in maternity practice inflammatory disease as one of the things that we encounter to your knowledge, and at the end of it, we'll have a discussion around. Just a few housekeeping rules that you notice. I'm just about to turn on some host tools that I want to alert you to. Number one, once he starts the presentation, you'll be unable to unmute yourself. Neither will you be able to start your video, so that there's no disruption in his presentation. As well, so that with the bandwidth, those who don't have a strong bandwidth would be able to still join the presentation. However, the chat box will be available all throughout his presentation. So kindly make use of it, put in your comments, your questions, your suggestions, so that at the end of his presentation, we can have a discussion around the topic pelvic inflammatory disease. Once again, thank you so much for joining us today. And I just want to welcome in a special way Dr. James Sunkari, who has agreed to do this presentation for us to update us. We are grateful, Dr. James. Dr. James, kindly take over and start the presentation. Thank you.
So, good afternoon. As Dr. Dogman rightly said, my name is Dr. James Sunkari, a medical officer at Golu Hospital. And today we are to have a discussion on pelvic inflammatory disease. So our presentation outline goes on like this. Objectives of today's presentation or today's discussion: introduction, epidemiology, etiology, then pathophysiology, classification, then some clinical presentations, and how PID or pelvic inflammatory disease is diagnosed, the treatment and its management, and we conclude from there. So as objectives, a contrast of the global and Ghana-specific epidemiology. That's one of the things. We will talk about the epidemiology of PID or pelvic inflammatory disease, but then we'll narrow it down to Ghana. They also explain some of the causative agent or diseases that cause PID. Then also apply some current diagnostic criteria. Then also select some appropriate outpatient and inpatient treatment regimens. Then formulate a management plan that include a follow-up, then partner notification. We'll get to realize as the presentation go on that PID has a close relation with STIs, that's sexually transmitted infection. So as introduction, we talk about pelvic inflammatory disease as an infection of the female reproductive tract. And that includes, let me just say, the female anatomy, right from the uterus, the fallopian tubes, and sorry. It's okay. So the fallopian tubes, ovaries, and some surrounding peritoneal structures. So I would like to underline peritoneum in this sense, because most of the clinical symptoms, that is the abdominal pain, the peritonism in severe circumstances, are as a result of the presence of the peritoneum within this. I mean, within this infected region. So its clinical significance. It's a major public health problem globally, which is often caused by sexually transmitted infections, particularly the chlamydia, Pseudomonas, and Neisseria gonorrhea, which these organisms are mostly sexually transmitted and can be asymptomatic or present with mild to non-specific symptoms, making some diagnosis challenging. And it's also the primary cause of infertility, or let me say preventable infertility worldwide. Preventable in a sense that when appropriate treatments is meted out, most of them recover fully and their fertility is regained. But if there's no timely treatment, that is where there's a problem. So the epidemiology of PID, or the pelvic inflammatory disease. So the incidence is difficult to ascertain precisely due to the asymptomatic cases that exist. But it estimates that annually 1 to 2% of young and sexually active women get infected or get a PID, or pelvic inflammatory disease. But there are some group of young people there are a group of people that are of high risk, and this includes the adolescent and young women, mostly less than 25 years, and also women with multiple sexual partners, and uh, women who have histories of previous STIs or sexually transmitted infection and previous PIDs, and also inconsistent use of barrier contraception. Now, the burden of this sequela include the infertility, which approximately 20% of women who have had PID stand the risk of having infertility issues, or as it said now, subfertility issues. We also talk about ectopic pregnancy. There's also an increased risk, close to 6 to 10% fold of ectopic pregnancy. Then also chronic pelvic pain, which affect close to 20 to 30% of women. And one of the severe complications which arise from PID, which is a tubal ovarian abscess, which is a serious complication from PID. Now, talking about Ghana, we have a high STI burden, where in Ghana there's a high prevalence of STIs, which are primary drivers of PID, or pelvic inflammatory disease. A study that was done in Kumasi showed that a prevalence of 19.5% of trachomatis, that's chlamydia trachomatis, among pregnant women. That's Aubrey Korang et al. In 2020. Another study also reported a prevalence of 11.8% among women in Accra, or in an STI clinic in Accra. This only shows that while there's a high burden of STI burden, PID is also following. As it is a high burden of PID among some young people in Ghana. And another issue is that PID is a common diagnosis, which is a leading cause of gynecological morbidity and hospital admissions in Ghana here. Now, there are some few challenges when we talk about diagnosis of PID. I'll just add that to the epidemiology, because it creates a gap in getting the actual epidemiology in Ghana here. And some of these challenges include a limited diagnostic facilities. That is, there are no sophisticated diagnostic tools available in some localities to actually diagnose certain pathogens, especially chlamydia and gonorrhea. And also the use of the self-medication and the use of herbal treatments, resulting in delay in presenting of some symptoms, and also seeking help. And also the issue of stigma, because it's STI associated, there is this stigma of STI. Someone with STI is assumed the person is promiscuous or something. So people tend to hide it when they have these STIs. That could be treated and probably prevent PID. And the issue of poverty and health access, though in some communities there's still this challenge of accessibility to quality healthcare. Yeah. So talking about the etiology, we just briefly talk about some of the risk factors. So as I earlier on stated, sexually active young people or young age, multiple partners, previous history of PID, then the the practice of distracting the female flora, the vaginal flora, this creates room for the colonization of by certain pathogens within the vagina, and which might ascend, as we see in the pathophysiology, which might ascend, causing a severe infection of the whole female reproductive system. And in some instances, the use of IUD, the intrauterine devices, as contraception. Now, the primary the causative agent, which, as I earlier on stated, is sexually transmitted, is one, chlamydia, trachomatis, which is the most common, and Neisseria gonorrhea. But let me just chip in this. Chlamydia trachomatis, as I usually say, is the slow poison, because this is what will stay in you for over years, close sometimes 10 to 15 years, without showing any form of severe symptoms, but great, go about destroying the whole female reproductive system and either forming some abscesses or some serious collections within the female reproductive system, which later result in adhesions, blocking female tubes, the fallopian tubes, and resulting in some fertility issues. And Neisseria gonorrhea is also another cause. Now, other associated microorganisms, which might include Mycoplasma genitalium, which is on an increasing rates. And we also have other anaerobes, there's a bacteroid, and Gardnerella vaginalis, Haemophilus influenza, then some enteric gram-negative rods as causes of pelvic inflammatory disease. Now, in a nutshell, it is seen that the actual etiology or the etiology of PID or pelvic inflammatory disease, as in the textbook, most textbooks might define as being polymicrobial, and which will be seen in the management or treatment of pelvic inflammatory disease. So since it's polymicrobial, to be seen that in the management or treatment, we have, use of different or combined use of antibiotics, naturally to treat pelvic inflammatory disease. Now, the pathophysiology of PID or pelvic inflammatory disease, where we'll go stepwise. Stepwise, as the whole female reproductive system goes up, that's from out to in. We talk about the first ascending infection. That is in the initial STI, that's chlamydia or gonorrhea, which infect the cervix, causing cervicitis. Then the microorganism tends to ascend through the cervix to the upper genital tract. So when it gets to the uterus or endometrium, it causes the endometritis. Then it ascends and it gets to the tubes and peritoneal spread. So when it gets to the tube, that's where it can result in your salpingitis, cause an inflammation, edema, and sometimes purulent exudates, damaging the cilia, that which usually line the epithelium of the tubes. And also, this infection can spread or can spill over into the pelvis. And as earlier stated, you will notice that part of the peritoneum covers the pelvis. So this can give you some symptoms of peritonism. And in very severe forms, you can have what they call the Peters syndrome, which is a perihepatitis. One of the severe complications of PID. Then the final stage, the last stage or step where we talk about the sequela formation, that is, in the process of healing, there are scar tissues that are formed. The scarring results in formation of adhesions and most often lead to tubal occlusions. And some of the scarring directly cause infertility. Others can result in ectopic and chronic pain. And when the pus collection sometimes is beyond certain volumes, leads to a generalized sepsis. And in this case, we usually talk about a tubal ovarian abscess or TOA. Now, we talk about the classification of pelvic inflammatory disease. So based on this, the clinical presentation, You can classify pelvic or PID as acute or subacute or silent. Acute when they are symptomatic infections ranging from immediate which require immediate treatment. And a subacute or silent PID usually is asymptomatic or minimal symptoms, sometimes atypical symptoms, which often the diagnosis is difficult, and which in these cases are mostly dangerous because appropriate treatment is not meted out, and this disease can progress into the later stages, resulting in infertility in some cases. Yeah. Now, also based on the severity, CDC guidelines also talk about mild to moderate PID as in cases of ambulatory patients who are not severely ill and can manage with oral medications or outpatient regimen. And in severe cases which include certain systemic illnesses where there's high fever, nausea, vomiting, uh, severe pain, and suspect when you can suspect or you suspect your tubal ovarian abscesses. And this might require hospitalization and IV therapy. Now, clinical presentation and diagnosis. So I would just want to summarize it into this form because I've already mentioned some of the generalized clinical features like the fever, the abdominal pain, and other things. But then, just want to classify it into these forms. We have some of the clinical presentations and signs that can be elicited. We talk about the uterine tenderness, the anexial tenderness, and cervical motion tenderness. Uterine tenderness, sometimes during palpation is perceived, you notice that there are signs of peritonism. Palpating in the hypogastric region, you notice some tenderness. And prior to this, some come in complaining of abnormal vaginal discharge, or prior to these symptoms, they complain of abnormal vaginal discharge, which usually have a bad odor, sometimes come with itchiness and uh, I mean, other signs and symptoms that can come with it. Then, on examination, as I earlier mentioned, is uterine tenderness on palpation, or sometimes during your vaginal examination or bimanual examination, you will notice that there is tenderness on palpation of the uterus, and even on palpation the anexa, you will notice severe tenderness. And trying to mobilize the cervix, patient usually complain of severe pain. That's what we refer to as cervical motion tenderness. So in some minimal diagnostic criteria, we look at empirical treatment, especially in young female who are sexually active, or women who have sorry, with one or more sexual partners. So some additional diagnostic criteria include one, temperature or high fever, then abnormal or vaginal mucopurulent discharges, as earlier mentioned. And in some cases where it's at present, you can do there's usual abundance of saline microscopy in the vaginal flora or vaginal fluid. Then usually ESR or C-reactive protein is also done. Then there's also laboratory documentation. That's in the case you can do a high vaginal swab uh, for culture and sensitivity and to test for Neisseria gonorrhea and the chlamydia. So for definitive criteria, usually it is encouraged to do this histopathology as evidence in the case of endometritis, a biopsy, and sometimes doing a transvaginal sonography is important. And in where it's available, MRI can also show fluid-filled tubes and with or without free fluid in the pelvis, or in the case of a tubal ovarian abscess, it could show. And in where in some places where it's also available, you can do the laparoscopy, which is more of macroscopic because you see the pathology itself. I mean, when you do your laparoscopic surgery, see the abnormality showing, and some collections within the pelvis, abnormalities within the tubes, the edema in the whole female reproductive system, which are usually seen laparoscopically. So we come to the treatment and management. So in the treatment and management, look at certain general principles. So the goal of this treatment is to eradicate the infection, prevent a long-term sequela, and provide your partner management. So as earlier mentioned, it's STI related. So you don't just treat the patient alone. Sometimes you have to bring in some counseling, talk to the patient as to treating partners to avoid recurrent infections and to prevent the spread of some of these STIs. You also mete out empirical treatments, which is initiated immediately upon presumption of the diagnosis to prevent permanent damage, or because the delay could be detrimental. Then usually we include broad spectrum coverage. That is, regimens must include treatment of Trichomatis, the Neisseria gonorrhea, and other anaerobes or gram-negative facultative bacteria. Then test for cure, so you can do the appropriate test for the gonorrhea, and in some cases, do your culture and sensitivity. That's the cases where you have resistance, you change your regimen. Though routinely, chlamydia is not tested for because of the complexity in terms of the test and other equipment that will be needed. And the last goal or the last principle talk about treatment, partner management is essential. So in these cases, within 60 days of treatment, clients is usually evaluated, especially with partners and partners who are treated, so to avoid reinfection. So in the treatment management, first we look at the outpatient base. This is from the CDC 2021 guidelines. I might chip in some of our local treatments because because some of the medications are not, you can't find them in some places, so we'll just have to replace them with some other. But from the CDC guidelines 2021, the first regimen seen, we talk about the ceftriaxone 500 milligrams starts, which should be given. Or in some cases, when the person is less than 150 kg, give 250 milligrams IM. Then cefoxitin 2 grams IM can also be used together with probinacid 1 gram orally. Then this plus doxycycline is also used. So let me just take it here. Doxycycline and other medications like azithromycin are usually used in these cases, targeting our chlamydia, then Neisseria gonorrhea. So it could also be used with or without metronidazole, 500 ml twice daily for 14 days. So another thing you also notice that such treatments are usually prolonged, that is up to 14 days, and in some cases could be extended to 21 days, depending on the severity or what is expected. Now, regimen B for outpatient cases, we can put a patient on levofloxacin 500 milligrams daily for 14 days, or ofloxacin 400 milligrams twice daily. But where we are, most facilities might not have ofloxacin, so levofloxacin, yes, might be present, but in some cases might not be present. So there are other medications that could be replaced with it. So this with your metronidazole, 500 milligrams twice daily for 14 days. Sorry. Hello.
Dr. James.
I'll go ahead because
yes,
some calls
please.
are. Okay. Thank you.
That's fine. We can hear you now.
Oh, okay.
All
Now,
right. Okay.
inpatient management regimen from the CDC guidelines 2021. There are certain indications for inpatient guidelines. Hospitalization. First is pregnant women, or in the case of pregnancy, it's automatic. You have to admit the client. The cases where there is a lack of clinical response to oral treatments, and in some cases where there's inability to follow up, or for follow up to be done, or where oral medications cannot be tolerated. Then in other severe, when there's severe illnesses resulting in nausea, vomiting, high fever, or in cases where you suspect your tubal ovarian or confirm a tubal ovarian abscess. So for the inpatient regimen, we talk about the use of hepotatan, titan, 2 grams IV twice daily, or the cepositin, also 2 grams IV 6 hourly, together with your doxycycline, which is given 100 milligrams twice daily. Then the other regimen includes use of clindamycin. Let me just say high dose clindamycin. In this case, we talk about clindamycin that's 900 milligrams IV, given 8 hourly, together with gentamicin, with a loading dose of 2 milligrams per kg, and with a maintenance dose of 1.5 milligrams per kg. Then within maybe after 24 to 48 hours, based on the clinical improvement of the client, you could switch to the oral medications, and you continue with the use of doxycycline, with or without metronidazole, to complete the 14 days course. Yeah. But we might also see that within our local setting, some cases, some regimens are used interchangeably. Some local within our local settings, most often we see the use of ciprofloxacin together with metronidazole, then your doxycycline. In some cases, clindamycin is combined together with levofloxacin, then doxycycline. Then now in current studies have shown the use of azithromycin, a single dose, once daily for 3 to 5 days, together with either your ciprofloxacin and your metronidazole, as some of the regions that are given. They depending on the availability of some of these medications. Now, the treatment and management of tubal ovarian abscess. So first, the diagnosis is confirmed by your ultrasound or your CT scan or MRI, where you can do it. Now, management include hospitalization, IV antibiotics, as per the regimen which I've said earlier on stated on. The use of the IV medication. Then sometimes we could do an image-guided drainage of the abscess, depending on the volume. That is the pericutaneous or transvaginal drainage, if necessary, in case of large abscesses, mostly 6 to 8 centimeters. And in cases where the abscess is not, there's no response to antibiotics within 48 to 72 hours. In some cases, surgical intervention, that's laparoscopic or laparotomy. Laparotomy could be done to that is, but most often the surgical intervention is reserved for cases where this abscess ruptures and becomes a surgical emergency. Now, as Leon mentions, this is not just treating the patient, allowing the patient to go home. Like most of our OPD clients, they need to be follow up with these clients, be it an inpatient or an outpatient base, because you need to reevaluate to see whether the treatment method out is appropriate one and is responding. The client is responding to treatment. As I already said, the treatment must be appropriate because this is to avoid future, complications like the subfertility, which I earlier mentioned. So reevaluate within 48 to 72 hours to ensure clinical improvement. And you screen and treat for other STIs, including HIV and syphilis. And you also provide counseling and long-term sequela, counseling on long-term sequelae, and which is an importance of safe sex practices. Then, in the case of prevention, you routinely have to use routine screening of asymptomatic sexually active young women for chlamydia and gonorrhea. Also, the use of barrier protective like the condoms to ensure safe sexual habits, and also education that's in the public health campaign targeting adolescents and high-risk groups, and partner notification and treatment is also critical in this case. So in conclusion, PID is a common and serious complication with devastating long-term consequences for reproductive health. The epidemiology in Ghana reflects a high underlying STI burden, compounded by diagnostic and access challenges. Then the diagnosis is primarily clinical, with a low threshold for empirical treatment to prevent sequelae. Treatment must be broad spectrum, covering the polymicrobial nature of it. And the partner is not, management is not optional, but it's a cornerstone for effective treatment and public health control. Thank you.
Excellent. Thank you so much, Dr. James, for an excellent job. This has been concise, this has been straight to the point, and I'm sure it's updated a lot of us on pelvic inflammatory disease. I've learned a thing or two, and I'm sure our participants have as well. So guys, if you have any question, any comment, any suggestion, kindly electronically put up your hand, and I'll be glad to unmute you to ask your question or make your contribution. So the floor is open. Just put up your hand and I'll be glad to do that. Hi, Kelly. Your microphone is on. Yeah, hi. Dr. James, can you guys hear me?
Yes, I can hear you now.
Okay, great. Yeah, so I was just asking if anyone has any comment, any question, kindly put up your hand and I'll mute you to go ahead to ask your question. Yeah, hi, Lydia. Please go ahead and unmute yourself and then make your contribution.
Please, thank you very much for this opportunity. Please, mine is a question about we those that are at the Chiefs campus. You know, some of us, we are far from the hospitals. So, and during the presentation, she made mention of the labs that we are to do before you treat the woman. So I want to ask whether you can also use the signs and symptoms and the complaint that the woman will give to treat the woman, or unless you do the labs before you can treat the woman. Thank you very much.
Thank you. Dr. James, will you want to pick that? Hello, can you guys hear me?
Yeah.
Okay, great. Dr. James, are you there? Okay, so I think maybe James's line is off. I'm sure he'll come back. But your question, Lydia, definitely we are guided by clinical signs and symptoms, right? And that gives you what we call a presumptive diagnosis. The way to go, the best practice will say that you need to confirm the diagnosis so that then becomes a definitive diagnosis. But of course, there's another thing which is quite common in our environment, we call it uprooting, where resources are limiting. there are certain things that we are able to do. And like I always say, we don't treat dead patients. We treat people who are alive. And so if at the CHIP center, that is all that you've got, you err on the side of caution. So you can then start the treatment and send the person to an appropriate center where the definitive diagnosis can be made, so that then he doesn't have to be on antibiotics without having to confirm whatever your diagnosis is. I hope it brings clarity to your question. Lydia?
Thank you very much.
All right, fantastic. So any other person with any question, contribution, comment, feel free to put up your hand. Don't feel shy.
Dika na lak nyim la na ka yim wa papa. Na ka yim wa ling nyim. Nyim na
Any other person with any question, please feel free to ask. All right, so Matilda has her hand up. Matilda, please unmute yourself and go ahead.
All right, good afternoon.
Good afternoon.
Mine is not a question, but I want to commend you for the good work done. It's been helping us and equipping us to actually help our patients, especially with those on the deprived places. So I want to say thank you and just continue doing it. Thank you.
Great. Thank you so much, Dr. Matilda Ekufo, for the commendation. We are grateful that you do recognize the efforts. And thank you, Dr. James, for making time to take us through this presentation today. So before you came in, Matilda just was commending us for taking time to do these presentations. They help to update people. So just so that you are aware, Dr. James. Yeah, so any other person with question, comment? Yeah, so yeah, Derek, please go ahead. You can unmute yourself and then, yeah.
Doc, actually, I wanted to post my question on the comment section, but when I tried, I couldn't. But my question is that in a reproductive age woman presenting with uterine fibroids and then symptoms suggestive of pelvic inflammatory disease, as a clinician, how do you differentiate whether her pain and then abdominal bleeding or symptoms are primarily due to the fibroid or an active PID, and what investigations are essential to guide in appropriate management?
Okay, great. Thanks, Derek. So, Dr. James, do you want to take that?
Okay, let me attempt it. So with the issue, as I earlier stated in my presentation, with PID, depending on the clinical presentation, because normally in fibroid, no matter even if it comes in a degenerative stage, most of the time the patient doesn't present with fever. There's usually no vaginal discharge that is offensive or mucopurulent vaginal discharge. But in the case of PID, most clients come with such symptoms: fever, severe lower abdominal pain. Sometimes when you do examination, the cervical motion tenderness. But in the case of, your fibroid, a patient might not present with such symptoms. So the fibroid, even if it's the degenerative state, that's when most of them come with pain and or some with some meteorrhagia, like some menstrual issues. That is how usually fibroid issues present themselves. But there could be some conflicting stages. But to as I earlier mentioned, to differentiate it, with your diagnostic tools, you can do your ultrasound, which will tell you that the patient has let me say fibroid, which is usually seen in the in the ultrasonography. Sometimes with a PID, you might only see some collections in the case of your tube ovarian abscess. You might see the collection, which is very obvious, or with some minimal fluid or moderate fluid in the porch of Douglas, as might be recorded by some sonographers. But let me just take the opportunity to clarify something. I know most of the times we have seen this in sonographic reports that they will do an ultrasound, then they'll see minimal fluid in porch of Douglas, then they'll write Curie PID. This is not. Let me just say, it doesn't necessarily mean that the client has PID. Sometimes when there is a process going on within the female, the pelvic, you will have some collection in the in the porch of Douglas. And normally there's fluid in the porch of Douglas. It's just that it's insignificant and very minimal. So when the ultrasound picks it up, doesn't necessarily mean that it's PID. I just wanted to clarify this because I thought somebody would have asked this, because I mean it's a very common thing that most sonographers will report and write Curie PID. Though it's one of the causes of collection or fluid in the porch of Douglas, but it is not the only cause of fluid in the porch of Douglas. But I just wanted to chip in this, by the way. I don't know whether you are okay with my answer.
Oh yes, absolutely. It's great. And like you did mention, I thought someone was going to ask that because it's a very common thing, especially in rural environments, without very trained radiologists and diagnostic sonographers. A couple of times, people just keep going for treatment for PID because there's some minimal fluid in the pouch of Douglas. Yeah, so thanks for bringing clarity to that. Any more question? Please feel free. We still have about 15 minutes to the top of the hour. Just feel free, put up your hand, I will mute you, and then we can have a discussion. Or if you have a contribution to make, please don't feel shy. You can help us to update our knowledge. Anything on PID, or if you have a question, please raise up your hand and I will mute you. Looks like, Dr. James, we don't have any further questions. So I just want to once again thank you so much for making time to lead us with this presentation on pelvic inflammatory disease. It was quite insightful, it was concise, and we learned a lot. And like you see, Emmanuel and a lot of people applaud you. It was great. We enjoyed it. Thanks a lot. And I want to thank you, participants, for joining today's session. We are grateful that you could join. Kindly follow us on our social media handles, and then you get to know the next topic we'll be presenting on. So we are on Facebook, same name, Ghana Medical Help. We have a WhatsApp channel, Ghana Medical Help. We are on LinkedIn, same Ghana Medical Help. So we are on YouTube. So this presentation is being recorded and would be put on the YouTube channel, so that those who could not join, or if you join late, or your network did not permit you at some point, you still have the full recording. So we are grateful, and thank you, Dr. James, once again. Thank you all participants for joining us for today. My name has been Dominic Akatema, and I'm glad that we had an excellent meeting today. Please take good care of yourselves, and God bless all of us. Bye-bye.
Thank you very much, Dr. Daniel.